Okay, hi everyone. My name is Fernanda Polanco. I'm a nurse practitioner fellow, and I currently work in Victoria with youth. I've worked with a youth intensive case management team for the past 5 years. I'm gonna just pause when there's announcements, so just so you all know, otherwise you guys, you won't hear me. I'm presenting today on the powdered fentanyl program. Of course, I want to start off by having a massive thank you to Dr. Christy Sutherland, who's here with us today. Thank you so much, Christy. This is her project. She created it, among other fentanyl product programs. So I just want to start off with that massive congratulations, or thank you. Of course, we want to respectfully acknowledge the land on which we're gathered today. It's the ancestral, traditional, unceded, meaning stolen and never given up territory of the Coast Salish people, including the Musqueam, Squamish, and Tsleil-Waututh nations. I also want to respectfully acknowledge that I live and work in a different area, the unceded, stolen, traditional territory of the Wasanic, Lekwungen, and Songhees people. Sociologists talk about this all the time. It's really easy for us to see when we're swimming against the stream. I'm brown, I'm a woman. And so there's these times where I'm really aware of oppressive movements. But I'm also somebody who lives in this society, and I got my first nursing job when I was 21. And so I've been shaped by this system that's colonial and that's racist, and it is anti-Indigenous. So when I've been in these situations, and everyone here has, where we've, heard something that's so awful, and we haven't said anything because we've chosen our own comfort in those moments. But it is the comfort over the survival of Indigenous people, and that's whenever I make land acknowledgements, it's always with that constant reminder that that's something that we just need to be better at. I don't have any conflicts of interest. Again, a massive appreciation and thank you to Dr. Christy Sutherland and the PHS team. To Tim Gauthier, who I'm sure will be here any minute, but he's my NP stream director. He's also the nurse practitioner at Insight, who has a powdered fentanyl program himself. And Matthew Kofold, I don't think he knows that I'm doing this, but this is the librarian that helped me out. It's like incredible what he got for me. And so it's really him and all librarians everywhere. Just a massive thank you. I'll be talking about colonialism and racism and death and loss, and that is awful and triggering. And so those first three references you probably are aware of, but the other three, Hope for Wellness, that's a 24/7 Indigenous specific mental health resource. The Clue Us crisis line that has three different streams, one elder and youth and general stream for, again, 24/7 Indigenous mental health support, and the 833 Métis BC line. Just a really brief overview. Opioid use in BC, we'll talk about that quickly. History of substance use law and prohibition in Canada. Prohibition, the paradox of prohibition, and the evidence, harm reduction, and safe supply. What are our current safe supply options, predominantly talking about opioids. And then we'll finally get to the what's new, the powdered fentanyl program at PHS, and then kind of what some final thoughts are. Opioid use in BC. We probably all know in April 2016, BC declared a public health emergency from the lives lost from the toxic illicit substances. In 2023, which was last year, we had the highest number of overdose deaths, 2,511 people passed, or 7.1 people a day. 70% of those were between the age of 30 and 59, and 77% were identified as male. The most common route of consumption is smoking. The area of highest lives lost were here in the Vancouver Coastal and Fraser Health authorities. And we do know that it's fentanyl predominant, right? Fentanyl is driving this. In 2016, we had 67% of fentanyl detected in overdose deaths, and then in 2023 it was 83%. But we also know that they're not the only part of this picture, right? There's stimulants. 46.9% methamphetamines, 18.3% involved alcohol, benzos, 40.2%. So it's complicated. This is an overwhelming picture. Intendedly so, but I'm just asking to focus on a couple of things. 2023, the highest number of lives lost, 2,511. In December, we lost 7.1 people a day and 219. And overdose, death, drug poisoning events are the leading cause of unnatural death in BC, but also the leading cause of death between the age of 10 and 59. We for sure absolutely know the evidence is very clear that this is a disproportionate impact to Indigenous people. That's not exclusive to addictions medicine. That's everything, but it's very clear here. First Nations population had a 5.9 times the rate of death in 2022 related to drug poisoning events. First Nations women died at 11.2 times the rate of their counterparts in BC. And in 2017, this is the latest number that I could get, Indigenous youth who use substances were 12.9 times more likely to have a fatal drug poisoning event than their non-Indigenous counterparts. So how did we get here? Oh, goodness. Okay. In the 1500s, yeah, I'm going back that far. The 1500s, that's not popping up. Oh, there it is. We'll just leave that up. The European colonizers, white colonizers, came from Britain and France and came to Indigenous communities, and with alcohol, that was their substance of choice at that time. It was very widely used, and it was brought here, and it was used as kind of like a, you know, something for trade. And at that time, there was this growing kind of push of this moral reformers that were finding alcohol as what they found as this corrupting force. In the 1700s to the 1800s, psychoactive substances were still totally illegal. Coca was found in wines and elixirs, and opium was used widely in Asia and in Europe, and again was brought over here to Canada. You know, this next period is really important, this temperance movement. There were a few things happening at the same time. So firstly, this movement was brought on by Protestant churches, and it was really, this is the seed of this moralistic view of substance use. So if you drank alcohol, you were immoral, and if you did it, you were morally pure. And so this really was driving this anti-Indigenous racism. This was like such a big part of it. Of course, at the early 1800s, the Indian Act was also created and created a whole bunch of stipulations around alcohol use and Indigenous populations. Like, for example, they weren't able to access Indigenous, someone who was status Indigenous was not able to access any establishment that sold alcohol. And at the same time, there was also the railway that was being built, and it was being built predominantly by Chinese men. It was coming from east to west. And in that time, these men would treat their physical ailments with opium, and that was something that they had done for a very long time. But certainly here, now that they were here in Canada, of course, that had continued. By the 1880s and the 1920s, the railway was completed. There were more, again, I told you, coming east to west. And so more Chinese men and their family were settling here in BC. And of course, that was also at the same time of this growing depression. So white men saw these Chinese men as taking the jobs that they were entitled to. And that was really driving a lot of this anti-Chinese racism. And it really kind of circulated around this kind of point of control, which could have been this with opium. In 1907, the race riots happened, which is actually when white men came and destroyed Chinese and Japanese run businesses. And there was just a shocking amount of harm to these people. And so the prime minister at the time, Wilfrid Laurier, sent over his minister of labor, Mackenzie Kang, to kind of investigate what was happening. And predictably so, you could probably... You could probably imagine who he was talking to. And so in 1908, the Opium Act was the first act of prohibition here in Canada, and it barred people from using opium. So if they used opium, they would be charged $50 to $1,000 fine, or if they couldn't pay, 3 years in prison. And again, starting to think about, despite not only Chinese people using opium, who might be getting the different charges. There were several amendments between the next, that time in 1960 that added on more substances and continued to kind of criminalize the associated substances. So, by 1955, the federal government created this special Senate committee to kind of look, and it was no denying it. There was more substance use in Canada, and so they divided these people who use substances into three groups. And so the first one was medical addicts, and so they described these people as people who had had a substance use disorder because they were being treated by a medical, condition. And the second one being professional addicts, people who could work and also use substances. And the third grouping, which is clearly the highest volume grouping, is they called criminal addicts at 74%. And this is important because they made some stipulations around what they had access to. So certainly not any illegal substances, but they were also really heavily and strongly encouraged to, of course, go to treatment, both voluntary and involuntary. By 1961, there was a Narcotic Control Act, again, another kind of criminalization of substance use, and a few things happened. They increased the maximum sentencing from 14 years to 25. They also had the power to hold people in preventative detention for an undetermined amount of time. And by 1969, it was pretty clear that substance use was a public health issue. So again, the federal government, there was this inquiry of non-medical drug use, the Ledane Commission, that kind of looked at all of this data, and at their final report at 1973, said we need to incrementally shift away from criminalization of substance use because those harms actually outweigh the harms of using substances themselves. They also said, one of the things I didn't mention, the special Senate committee, that they had previously said, like, we should be using these fear-based tactics to stop young people from using substances, which of course the Ledane Commission said, that's not effective. By 1987, it'll come. 1987, the federal government created this Canada's drug strategy 4-pillar, how we're going to, treat substance use care. And they had these 4 pillars: harm reduction, prevention, treatment, and enforcement, meaning policing. By 1996, again, this continued, Prohibition, Controlled Drug and Substances Act, again, continued to kind of proceed towards the criminalization of substances, totally ignored the Ledane Commission. And by 2007, the National Anti-Drug Strategy under the Harper government re-looked at this 4 pillars and said, you know what, we don't actually need this harm reduction pillar, but we do need to kind of further put money into enforcement. And in 2016, the Canadian Drug and Substances Strategy by a new federal government looked at this 4-pillar strategy and reintroduced harm reduction. And at the same time, here in BC, we declared an opioid crisis. So do those things kind of connect? Do those seminal seeds of racism and these prohibition acts that were really driven by those things, how did we get to the place that we're at today? Well, this has been described for a long time. This is the original. This is why I had to have that shout out to the librarian. This is the original photocopy of the original publishing of The Paradox of Prohibition. And this is by a psychiatrist, UK psychiatrist, Dr. John Marks. And he described in this original article saying, there are lots of examples of prohibition worsening substance use and its related morbidity and mortality. And there are examples throughout the world. Liverpool, the USSR, this is a while ago, the Iranian Revolution, but he specifically talked about the States, where he noted in 1985, they were spending thousands of millions of dollars a year on the most rigorous enforcement of prohibition in history, while at the same time noting 5,000 new drug users a day. And so he describes this: promotion stimulates consumption while prohibition fiddles it. We currently have the former with alcohol and tobacco, and the latter with other drugs, and society suffers at both extremes. So you can see along the y-axis, health and social harms, and along the x-axis, prohibition all the way to complete legalization and promotion. And really, on the left-hand side, we've had what we've had for a long time. Drugs become more adulterated, more toxic, people become more secretive. Safety continues to worsen. We have costs like, cost to the criminal system, to the healthcare system, not to mention lives lost. And then on the right-hand side, we have, total free market, which means lucrative business. There's money to be had with promoting the actual use of each substance. And again, it's related health harms. And so really there's this public health bubble in the middle, and nobody really knows where that sweet spot is. But as you can see, there's regulation, there's access, there's prescription. Okay, so what are the claims though about prohibition? So increased violence. This is an old systematic analysis from 2013, but it looked at data from 1990 to 2013 in 188 countries, and basically it found that there was this increase in this interpersonal violence from this time frame by about 18.4%, and interpersonal violence, connected to substance use and its related activities. And it found that actually Latin America, which had a disproportionate impact, actually had this as a top 5 cause of death in 15 countries. This one is, so interesting. Someone by the name of Osario looked at policing data, 1.6 million encounters in the Mexican war on drugs, and said, we've had drug trafficking groups here for decades, but why is it that violence is now more widespread and increased despite having a drastic increase on the policing and the enforcement? And he found these kind of these two phenomena. So the first one he called centrifugal. And so basically, police are monitoring these main pathways of drug trafficking, and, drug trafficking groups are smart. Like, well, we're obviously not going to go down those routes. So we'll go down these back routes in these smaller communities, and there's this spread of violence. And then this other aspect he called centripetal, which was basically when, the policing would kind of narrow in on a particular drug trafficking group, and the associated groups kind of around would note, okay, well, they're somewhat weakened, and so let's double down and really take out the competition, and thereby increasing violence. This, again, an old systematic review, but still very pertinent, from 2011, again, mainly looking at the US and Australia, but found that, of course, increasing drug law enforcement did statistically, in a significant way, increase the drug market violence. This is another, again, older, but rise in femicide and women in drug trafficking, specifically looking at Latin America, and found that the sexual assault and the killing of women is used as a tactic to terrorize other drug trafficking groups and communities. And then, of course, this is from 2018. This is from here in BC. Looked at all sorts of data of the impact of people who don't have, who are houseless, and found that women who had kind of these low-level charges and often PO orders that would kind of bar them from certain areas of town, like, for example, the downtown east side or the 900 Block of Pandora, Rock Bay Landing, those types of places, actually found that those women were at higher risk of assault, robbery, and murder. We know that it's lucrative. Prohibition to illegal markets. And this is from 2016, where they found this was the most lucrative market in the world, $330 billion a year, and that was from 2011. I'd be fascinated to know what it is today. Prohibition, Ivesons and Al from 2021 found that prohibition contributed to this unpredictable and irregular supply. It also, this is a Government of Canada paper that found, yes, it's fentanyl predominant, there's widespread toxicity, and again, unpredictable supply. The criminal system. So the interaction, the actual cost of the criminal system, this is again the same paper from 2023. The Canadian Drugs and Substances Strategy found that in 2020 we spent $10 billion in Canada on the enforcement of substance use laws. And our provincial health officer, Dr. Bonnie Henry, in 2019 wrote this paper, and she listed, there's harms, of course, of people engaging with the criminal system, often being put into custody for low-level offenses. Which of course put them at risk of, human rights violations, but also, these intermittent and oftentimes limited or poor access to medical and addictions care, increasing the rates of bloodborne infections. And then, of course, thinking about after the fact, employment or all of those different things that we need criminal record check for, like a loan or a mortgage or leaving the country. This is getting more granular. This was a retrospective population-based cohort study from 2023 using police data from Mariana County, which found that after an opioid-related drug seizure, they had a twofold increase in the fatal overdose rate within 500-meter radius. This was sustained over 7, 14, and 21 days. And so there's lots of ideas as to why this could potentially be. Maybe there's a new supplier, maybe there's an interrupted drug supply. I also wonder, does this create more secretive, more isolated use, a less social response to overdose? And is this happening in rich white neighborhoods? No, this is happening in marginalized BIPOC communities. Prohibition and stigma. Again, this is one of the things that's so, can sometimes be the easiest thing to see and sometimes the hardest thing to see. The self-stigma that somebody, who uses substances has these internalized low self-esteem. We know this. Difficulty accessing care. The social stigma going back to that moralistic view on substance use. And this is society and communities' thoughts on substance use. And then the structural stigma. This is us. This is the policies, and this is what I mean. We've all been shaped by this system. And so, do we connect people to the resources that they need to? Are they dismissed when they come to us? Again, just getting more granular. This was a Vancouver-based, community-based cohort study out of Vancouver looking at Indigenous sex workers, and they were looking at different experiences that might contribute to unsuccessful treatment attempts. So they found that police harassment was one of them, and they found that those who had experienced police harassment had the highest number of unsuccessful access attempts to treatment. And again, I can't say this enough. Last year we lost 2,511 people. The failed war on drugs is honestly really, really well known. This is a massive document from 2014 with some of the authors being the past president of Mexico, the past president of Portugal, of Chile, Brazil. Again, this is another group out of Johns Hopkins looking at the health impact of prohibition. Okay, the summary of literature of repercussions of prohibition. So, we know that this increases violence. We know that this creates an illegal markets, criminal organizations. It contributes to unpredictable and irregular adulterated supply. It contaminates drugs with other drugs. There's a high burden to the criminal system, incarceration rates, arrests. We know that we spend billions of dollars on this, and there's just an absolutely unknowable amount of harm from stigma and discrimination. So, on the other side, what's harm reduction? Harm reduction refers to policies, programs, and practices that aim to minimize the negative health, social, and legal impacts associated with drug use, drug policies, and drug laws. Harm reduction is grounded in justice and human rights, and it focuses on the positive change and working with people without judgment, coercion, discrimination, or requiring that people stop using drugs as a precondition of support. And that's a wonderful definition from the Harm Reduction International. It's really standing alongside someone and meeting them what they're at that year or that month or that day or that hour. And so there's plenty of examples of harm reduction, but just a brief look into, supervised injection facilities. Again, this is information that we know. This was a massive systematic review, 75 articles from 2014, promoted safer injection, access to primary care, decreased overdose frequency, didn't increase crime, nor drug trafficking, nor intravenous drug use. It encouraged proper disposal of harm reduction supplies, and for those that this matters to, there's less public intravenous drug use. And again, this was updated in 2022, mostly studies out of Vancouver. Again, significant reduction in overdose morbidity and mortality, improved injection behaviors, improved access to addictions care, and it didn't increase crime or public nuisance. And this was also, for those of you that have connections to Alberta, it was also looked at by a group in Alberta in 2021 that again found consistent results. So what's safer supply? Well, the BCCSU's policy direction is support the provision of pharmaceutical grade alternatives to illicit drugs to people who are at risk of drug poisoning events and death. And what do we know about it? I mean, this should matter. This is people who use drugs. This is what they've been asking for forever. This is also a part of that original paradox of prohibition, like looking at what that harm reduction, that public health bubble looked at. You know, this is a paper, I'm sure all of you are familiar with it, from earlier this year, Sloan-White and al., looking at this was a retrospective cohort study. It was an observational study, just under 6,000 people who had opioid or stimulant use disorder, and they did their best at an observational study trying to create this control group using propensity score matching. And kind of found people who had opioid or stimulant use disorder through various different databases, you know, MSDPR, health insurance, MSB, you know, hospital discharge notes, incarceration center. There were a ton. They also tried to control what they could for about 50 different variables. And this was between March 2020 and August 31st, 2021. And the results were the hydromorphone dispensation at least 1 day a week was associated with decreased all-cause mortality and overdose-related mortality in the following week, and that this was independent of OAT dispensation, and that there was perhaps this kind of dose-dependent, like the higher the dose and the higher the number of days dispensed actually improved that protective effect. And although I'm not talking a lot about stimulants today, they found, you know, not significantly associated with reduced all-cause mortality or overdose-related mortality. There was a significant decrease in odds of acute care visits for any cause, although there was no impact on overdose-related acute care visits. You know, it's hard. This was a very specific point in time, so it's hard to kind of place, you know, where we are today. But this is certainly encouraging in terms of like trying to meet people's, trying to provide a service that people are requiring. So what are the options that we have today for opioid safer supply? So the first is hydromorphone. It's prescribed risk mitigation, usually 8 milligram tablets, and they kind of, usually prescribers max out at 14 8 milligram tablets or 112 milligrams of hydromorphone a day. It's usually alongside OAT, and it's usually daily dispense, and it's typically unwitnessed. The fentanyl tablet, or the brand name being Fentora, maxes out at the tablet dose maxes out at 800 micrograms per tablet, and that's taken sublingually. And there, as far as I understand it, there's no max dose on really what people can have. It's, you know, it can be maintenance, it can be a PRN program. And then, of course, there's the sufentanil program, which can be taken orally or injected. And, you know, sufentanil having an extraordinarily high affinity to the mu opioid receptor, pretty potent analgesic effects. But the maximum on the BCCSU protocol is 250 micrograms 4 times a day, but I'm sure that different communities probably have adjusted this. The next one is the fentanyl patch program. This is another program created by Dr. Sutherland, and the PHS actually launched this in 2019, and this protocol that we have at the BCCSU is from 2022. And really, it was an intervention for folks who, you know, perhaps weren't the traditional OAT, or what they had wasn't quite meeting the need. And so, although it's listed as safer supply, you know, I have certainly seen it used as kind of this alternative for OAT, or sometimes an adjunct to their current OAT. But really, it's the same molecule for the same molecule, right? It's fentanyl for the fentanyl predominant illicit supply. Titrations can sometimes be challenging, right? It's a long half-life. Titrations can sometimes be a little, you know, every couple of patch changes. Doses typically range between 8 to 1,200 micrograms an hour, although I've certainly seen higher in community. But this is a closed loop system. People come in with their old patches, or if they've fallen off in a little baggie, and you know, it's very easy to see if those patches have been tampered with, and so they get new patches for their old patches. And it really is kind of this closed loop system. Okay, finally, the powdered fentanyl program. Okay, this was developed in 2022 by Dr. Sutherland and then implemented by their team at PHS. They originally started with using drug checking data and started off with 20 participants. If this program is really the epitome of nothing about us without us. So they did weekly feedback via surveys for various months, and that formula changed 16 times. And of course, they did this with a certified compounding pharmacy. But really, what I want to say is, whenever we talk about interventions in medicine, we think like RCTs and these big things. So it's really it's not something that we have in RCT or observational data. It's far too new for any of that. But this is something, again, that we're kind of tapping into that original paradox of prohibition. How do we treat illicit opioids for folks who are seeking opioids? We treat it with something that's consistent, the pharmaceutical grade that they know. And so it really is opioids for opioids. And so this is something that is certainly evidence generating, and the BCCSU is looking into is assessing this program throughout. And so what's contained in each capsule? So they started off with fentanyl, dextrose, and caffeine, and it turned into fentanyl, mannitol, caffeine at a 16% concentration, starting off at a dose of, I think, 250 micrograms. And they ended up with take-home doses of 20,000 micrograms. And to put this into some context, for those of you who are familiar with a Fentora tablet, like I said, it maxes out at 800 micrograms per tablet. The bioavailability of that is 65%. And so to get an equivalent dose using Fentora tablets, you'd have to take 40 tablets. This is can be administered through injection, intranasal, smoked, and of course it's tested consistently by Health Canada lab for accurate dosing. Who is eligible? People who use opioids, who are not fentanyl naive, people who use opioids, and people who are at risk of overdose and death. That's it. So how there are really these two models that we'll talk about. The first is this medical model, the SAFER model, and that's this witnessed program. And then the enhanced access model, the unwitnessed program. We'll get into the details of both of those two things. But to get started, basically, this person sees a prescriber at PHS. They have physicians, so they see a physician, and they're kind of assessed for like compatibility with this program. And then a second prescriber physician does a chart review, not a separate appointment. Really, it's just kind of, yep, we agree this person is a good fit for this. And then they're slotted in for titration. And so this is done over 2 days. So if they have a high known tolerance, this is the example of the high known tolerance titration process. They start off at 10,000 micrograms, they're observed, they leave, and they come back, and they're increased by 5,000 micrograms per dose. And at the end of it, everyone needs to show basically that, dependent on the program, that if they're a medical program, they have to finish at the 25,000 micrograms. They have to be tolerate that. And day 2, they can start that medical program, that 25,000 micrograms 4 times a day. If you're on the enhanced access program, well, they need to show that they're tolerant to the 20,000 micrograms, and they have this witnessed titration over a couple of doses, just to kind of make sure over a couple of days, and that's that. So really, when I heard about this enhanced access program, what was so striking to me is that this is a program that's unwitnessed and it's paid, but there really is real intentionality behind that paid component. And so I want to talk about that. But first, I want to talk about lessons from alcohol and smoking. So how does taxation and minimum unit pricing have an impact on tobacco and alcohol consumption? Really, this is something that we know. It's very well established that increasing that taxation on tobacco and alcohol does have an impact on its use. And so this is, a recent article by Lee and Al from 2023 from this group called Tobacconomics. It's a group out of Johns Hopkins that basically looks at tobacco use and its related economics. And it kind of looks at, they have this thing called a scorecard that they assess different, like I think it's 160 countries' ability to use taxation connected with cigarettes. And these 4 components are, price of the actual pack itself, affordability, so how affordable is it within that country, the tax structure, how do they use that tax, and then the actual tax, like the actual amount of tax. And so they found that, the higher the price, this kind of excise tax, the better they were at doing these things. Of course, this reduced tobacco use. And although this isn't in any way, shape, or form, PHS does not make money on enhanced access, but this, of course, showed it did increase tax revenue for their governments. So the question is, does the tobacco industry know this? So when we increase taxes, do they, what are they doing? And so this is a paper out of 2023, 37 articles, high and middle to low income countries that kind of found, what are they doing? And of course they know. So they do different things to try and undermine those tax policies to, of course, continue on this tobacco consumption, because that is good for business. The impact of alcohol control policies. So this is another systematic review from 2023, again, looking at studies published from the year 2000 to 2022, which again, although they said, we need to look kind of more thoroughly at these subgroup populations, but, the gestalt is doubling alcohol tax or introducing minimum unit pricing, reduce consumption by 10%, and restricting alcohol sales by 1 day a week, reduced it by 3.6%. And then, of course, this is another systematic review, tobacco, alcohol, and sugar sweetened beverages by Polanco and Al from 2023, another systematic review looking at this, which found that, there are short-term negative financial consequences for low-income households. However, the medium and long-term benefits are far outweighed that initial burden, and it's reduced healthcare costs, better health, better welfare. And so then there's always this idea of increasing tobacco tax, and how does that contribute to the illicit tobacco market? Because that's a thing. So you would think that would kind of drive or increase that market, but what they actually found was that it was impacted, but it just wasn't increased. It was actually decreased. Okay, finally, so the Enhanced Access Program, 20,000 micrograms per dose at 16% fentanyl concentration. Every take-home dose is the exact same dose, and that's actually done, quite thoughtfully with, for safety reasons. Then when that person leaves or it's home, they know exactly what dose they're getting. It's always consistent. That's approximately, the cost, or that's approximately 2 points of illicit fentanyl or down. And so what's the cost of about 2 points of down? It's about $20, which is the cost of each of these capsules, which is $20. And every single capsule, every single dose is paid by a participant. They're after the titration process, after they've been, the team knows that they have tolerance to this dose. It is no longer witnessed, and they're daily dispensed. There's warning labels on each of the packaging, and the number of doses varies. So basically, it's based on a prescription. And so, this is really, as described, it's like walking into a store that you've already been assessed for your tolerance. You know the product, you know that you're tolerant to it, you know what to expect. And there's already been a conversation about doses, and you can walk in and get what you need. And at that site, there's access to healthcare. You're buying it, you're interacting with a nurse. Yeah. So what does this mean for payment? It's really trying to tackle, like I said, there's true intentionality with every part of this program. So it's really trying to tackle the two ends of that. the first, it's the equivalent dose, but also the actual physical product, the amount to the unregulated supply. And then on the other hand, it's having a cost associated, trying not to, perhaps accelerate use and trying not to create this kind of like free market, of course. And so we're trying to tackle into that bubble that says, like there's some restriction, there's regulation, there's prescription, and there's assessment. This is Dr. Sutherland's slide from her presentation earlier this year. Basically, this is the summary, right? Like there's two. The first is the medical model. All doses are witnessed, 25,000 micrograms 4 times a day. The drug cost is paid for by the program. And so it's not only the drug cost, but of course you're thinking about the cost of actually hosting and having all of the interrelated disciplines at that site. The intensity, of course, is very high. If you want to get all of your doses, you have to come 4 times a day. It's paired often with OAT, and of course, there's pathways to recovery throughout. The second one is the Enhanced Access Program. After the titration process, every single dose is 20,000 micrograms. The costs are paid entirely by the participant. None of that money just goes right back into this program. And of course, it's a lower intensity, right? So people can come in and get what they want. So it could be, for folks who are using perhaps daily, or people who are using intermittently, and they can go on and do the other things that they need to do with their day. It can be paired with OAT, but of course, as they're coming in and they're engaging with people in the healthcare system, there's ongoing access and pathways to recovery if that's what that person would like. So, what are the limitations in healthcare and medicine? We think so much about is there a systematic review? Is there an RCT? Of course, after all of that information that we talked about, the first part of this presentation, there's not a lot of time to do all of those things. There's a lot of need, but certainly this is evidence generating, right? There are things that we can understand and that we can glean from, the paradox of prohibition, what we do know about what's happening right now. Another thing is the supply is changing. Dr. Sutherland, the PHS team are nimble, and they're changing. They're clearly not afraid of changing programs, but that can be challenging for a health authority. So it's hard to be that adaptable. And hospitalizations outside of St. Paul's or even this area, how if people are find that this molecule, that the fentanyl is working, it can be hard to adjust to different things if acute care doesn't have the capacity or the physical, the fentanyl. And certainly, what if people want oral options and all of these things? There's lots of other things that I'm sure if we can talk about. People aren't going to get a deal if they're buying 3.5 grams of, the enhanced access. But of course, so there could be certainly cost limitations. But where do we go from here? We've talked about this disproportionate impact to Indigenous people. So, that's something that I know that the PHS team is very good at. But in a bigger scale, how are we engaging and how are we working with Indigenous communities and Indigenous folks? And also, really at the end of this, there's 2 models. There's one that's quite medicalized, that's quite intensive, and folks need to kind of show up and be a part of that daily and throughout the day. And there's another model that really provides a lot of flexibility and really trying to meet people at their needs and maybe that's that they use down a few times a week, and so they're able to come back and kind of adjust that schedule. It's also empowering to be able to come in and to buy what you need and to leave with a receipt. Those things can't be, for a lot of us might not matter that much, but those things do matter. And, I can't talk about anything working with youth for the past 5 years without, talking about youth, right? This is clearly a dramatization. I'm not talking about toddlers or kids, but I can tell you as a parent, the fact that when my child turns 10, the number one way that she could pass away is from a drug poisoning event. That is sadness so profound that just drags me down to my knees. And I've been working again with young people for 5 years, and I really wish that youth meant fentanyl naive or opioid naive, or populations that don't interact with older adults, or they don't go to the downtown east side, or they don't go to Pandora, they don't go to the Rock Bay Landing. But that's a dream. They do. And I've seen firsthand how the exclusion of young people from these programs can be really, really harmful. So really it's just a last consideration of, safer supply, specifically, powdered fentanyl, of course, with restrictions and thoughtfulness and planning, but should be available to folks who are at risk of overdose, not just some people. And that's it. And there's this survey. It should pop up.
My name is George. I'm the Addiction Nurse Practitioner. I'm supposed to be here quite a bit earlier and I had a little accident. But I'm glad to be here now. And Fernanda, that was fantastic. Thank you for doing that. And Dr. Sutherland, thank you for being here. And thanks for all of this work. You set us up so well to do this work. Thank you. We're going to open the floor now to questions. Yeah.
I don't have a question, so much as a comment. I really appreciate how you drew out the context and the history when bringing us to this question of what are we talking about at all, because that's so important in terms of understanding how we got here and where we need to go. And I also like to comment on the fact that, as you're saying, that Indigenous people are disproportionately impacted. That's not an accident. That's on purpose. It's Indigenous people losing their power, being unwell. It furthers the colonial project of making a justifying control over Indigenous people, because if more Indigenous people are not well, then they can't assert their sovereignty over the land. Yeah. And we saw this happen by the British in China. 100 years that the British were importing opium into China is known as the century of humiliation, and it's when the Chinese were trafficked. So we see that it's not an accident that this has happened as a part of all the other suffering that colonialism happened. This is on purpose. So if we want to help people to make sure that they're not dying at this rate, we have to make a choice to further end the colonial project that we do.
Totally. Thank you so much. It was so well said. Yes. I'm sorry for all those in Zoom. I can't summarize that as well as you just said. Yeah. Yeah. I don't know that we
comments are more than welcome as well.
Yes. Yeah.
Julie,
oh, wow.
Well done. That was great. I'm curious the rationale behind charging patients the $20. Rationale behind that, I see it's the same price as the street code. So I'm just curious about. I mean, I have some ideas why that might be, but I'm curious what that is.
Yeah. I mean, that's what I mean about the intentionality. It's trying to cut out that it's like that bad third partner, as Dr. Sutherland often says. It's equivalent. So the desire or the gain from really selling or doing anything with that is basically it's trying to cut that out. It's also trying, as we say, it's trying not to kind of continue if it's this potential acceleration that, a lot of that could happen. But I'm not sure if Dr. Sutherland has any other thoughts on that. Yes.
So
yes. Yeah.
And when we first started, it was $29. And then as the program grows, we get cost savings in terms of bulk purchasing of the fentanyl, and then in bulk production of the fentanyl capsules. It's so granular, we have to pay for how many times we have to put PPE on and off at the lab and inside the compounding pharmacy. And so the bigger our orders, the less PPE we have to pay for. And so I hope to get the cost down to $15, but that will take increased volume of the program. Yes, we don't, as Fernanda said, we don't make money, it's cost recovery. And then I sort of joke with patients, because it is a little bit higher than the street value, but I say like, oh, well, your drug dealer doesn't pay your employees a living wage. Like, and so like, we are, and so they're like, oh, okay.
Yeah, excellent. It's a great question. These two are probably the best to connect. Yeah, I think, yeah, I might let you guys answer, because that's kind of more program specific. Yeah.
Yeah, it is like, it is fairly program specific. So I work at Insight, and I work in the safer supply program there, where I've prescribed powdered fentanyl based on the Portland model that Dr. Lynn developed. And our program is, it can be challenging if you're not an Insight participant, for sure, because we prioritize people who are coming to our site already, because they're going to be embedded in our program that's already running. It's not a separate standalone program. It's going to be one that's inside our supervised consumption site. So ours is specific to Insight participants mostly. We can accommodate outside referrals. It's just harder to do. So, and wait lists are long. It would be linking up to our intake coordinators. So just calling Insight and talking to the intake coordinators is one on 7 days a week. So that's your first point of contact.
And for us, it's just a referral. The enhanced access program, like for safer, it's sort of just full. Like we have the participants on it and they are stable and they don't really move. So we don't even maintain a wait list, because it's only going to call up a wait list in 6 months. It's too dynamic. And for enhanced access, we're trying to get referrals for people who will participate. And it's a very unique patient population, because ultra high dose fentanyl tolerance and then has money to purchase the program. So for our titrations, we want them to like come to the titration and like take the doses and then purchase the drug. We have 68 people in the program right now, and most of them don't come in and purchase every day. It's more intermittent, like goes with check week each month. So, you know, sometimes we get referrals, like especially in hospital discharge, that are like, oh, they can go to enhanced access if they want, and they come and you know, they're in renal failure, like, you know, they have all these other medical things that are, where you're like, oh gosh, like, you know, it's I don't want to give you, you know, just like it can get really complicated. So the addiction medicine consult service has like a one-pager about how to like call and how to do the referral to us, but it would be a discussion each time, because we want people who will participate in the program. Yeah, like so you guys have that. I don't know where it's going to put a little summary of the PHS services for our fentanyl and patch intakes.
Yeah, so we have about 5 more minutes if this clock is right.
Yeah.
Is there any anecdotal experience or observational data that's being gathered about patients who either self-report using fentanyl or have a history of fentanyl, and how they, like, their success with interfacing with this program? I'm just curious.
Yeah.
If that's
Yeah. Sorry, I haven't been repeating the questions into here, but that was a question about perhaps folks who are benzodependent through the adulterated fentanyl supply, and what that experience could be like, or is there any anecdotal evidence when folks are being brought into this program? And you know, that's something we did chat about with Dr. Sutherland. It's trying to treat, I think they've tried with like a gabapentin and trying to treat those symptoms of discomfort if they're, you know, if that's something that they're able to do. Yeah. Yeah, I think that's perhaps the summary. Yeah. Anyone else? That's good. Oh, yeah. Okay. Thank you. So wonderful. Thank you. This is Jen McKenzie. Thank you, Dr. Sutherland and your team, for the incredible work that you do in the downtown east side. Also a sincere thanks to highlighting, advocating for inequities for youth who use substances. Great. And there will be a Zoom recording. Yeah, it'll be available. I think that's all. Yeah, thank you.